I'd like to now reintroduce Dr. Laura Cheever, who is the Associate Administrator and Chief Medical Officer of HRSA's HIV/AIDS Bureau and the Ryan White Clinical Conference Co-Chair. So thank you, Dr. Cheever, who will be the moderator for Ending the HIV Epidemic panel discussion. Thank you.
Great, thanks very much. So today we're going to talk about ending the HIV epidemic, specifically focusing on what progress we're making amid the pandemic. This session is going to be a little bit different. We're going to have 4 different people presenting. I'm going to give a quick overview of ending the HIV epidemic, the structure of it, and HRSA's contribution. It'll be a little bit repetitive of what I said on the first day. Then we're going to have Eugene McCray, who's a Director of the Division of HIV Prevention at CDC, talking about CDC's role in ending the HIV epidemic and what they've been working on. And then we're going to really dig in deep. Vicki Cargill, who is an Assistant Commissioner in Baltimore City in charge of HIV services, is going to talk about their Getting to Zero plan. They received a little bit of seed money last year from the CDC, and she's going to be talking about the work they're doing to end the epidemic and some of the really novel approaches they're taking in the city of Baltimore. And then Dr. Magda Houlberg, who is the Chief Clinical Officer at Howard Brown Health, is going to talk about what they've been doing in telehealth. We've had several questions about telehealth and PrEP and how to do self-testing, and Dr. Houlberg can speak to a lot of those questions, and we'll talk about their experience there. So just the high-level recap. The goal of the Ending the HIV Epidemic Plan for America is to have a 90% reduction in 10 years of new HIV infections in this country, less than 3,000 per year, with sort of an expedited goal of having a 75% reduction in the first 5 years. So there are 4 primary pillars of this. First is to increase diagnosis. About 15% of people are undiagnosed in this country, and CDC is really taking the lead on that, working with the health center program. Second is to improve access to treatment, particularly among the people that are newly diagnosed and those who are out of care, who know they have HIV. The third is to beef up our prevention activities by really having national implementation of PrEP and expanding our syringe services. And fourth is to improve the ability of health departments to respond to outbreaks through molecular epidemiology and enhanced contact tracing. So in the first 5 years, we are focusing on 48 counties, DC and San Juan, as well, where 50% of all the new diagnoses in the last 2 years have occurred, as well as 7 rural states with substantial, 7 states with substantial rural HIV burden. And you can see those listed here. When you actually map out the counties and cities there, 49 of them actually fall into Ryan White Part A cities, what we call our Part A grants, into their jurisdictions. So in the Ryan White program, we're focusing on 3 groups. First are those people who have walked into our clinic at least once and are still not virally suppressed. That's about 13% of people that are in care with us. Secondly, we're focusing new and different kinds of efforts on the newly diagnosed, including things like Rapid Start and enhanced linkage and engagement, since we know that first year is a challenge for people. But third, most of our efforts are really focused on this last group, which is the 250,000 people we estimate who know they have HIV and are out of care. And for this group in particular, it's really about us doing things differently, retooling how we provide care and engaging with new partners and new ways of reaching these people, because they are getting services often somewhere in the community. How can we do things differently to reach them? So we received $70 million in 2020, and we funded our Part A and B jurisdictions I just showed you on that previous map. We've also funded a technical assistance provider to help us really capture the innovative things people are doing in disseminating those successes across programs. We also funded a systems coordination provider to help at the local level to bring in new partners and help coordinate across the jurisdictions. And we funded the AIDS education and training centers to improve workforce capacity, because we know that one of the major things we need to do is really build up the capacity of people to treat people, to diagnose and treat people with HIV. If that doesn't happen, this whole initiative is not going to work. The health center program was also funded. They had $54 million they released last year. And their primary sort of mandate is to implement pre-exposure prophylaxis PrEP. But as a part of that, they really need to improve the cultural competence, cultural humility of health centers for treating people who are at risk for HIV, who have HIV. They are going to have to really beef up their ability to make sexual health and have a sort of sex positive message be a part of health centers. So all of that is going to be potentially new. So we're very excited about that. And so they are all on board to do that. In the first year, they primarily funded health centers that are co-funded with Ryan White programs because we wanted to see what success would look like. And we knew that in co-funded programs, we'd have real champions for HIV prevention in those programs. So much of the work, we funded both the health centers and the Ryan White programs. We started our funded activities in March of 2020. So I think we all remember what else happened in March of 2020. And so most of the clinical programs that you all work in, health centers and health departments, have had to really focus their energies on COVID-19 and maintaining the services they had. So the thought of adding new and different services for ending the epidemic really was not on the table. However, we do realize that the things that happen, there are many things that happen because of COVID that can really help us. And the first thing is that we've had the adoption of telemedicine sort of overnight. And anecdotally, people are saying that they've really been able to improve their retention rates and reach people they couldn't generally reach. We've had the extension of medication refills to 90 days. Most programs were only giving 30 days before, insurance companies. And so that means that people don't have those 2 or 3 days they'd often miss as they scramble to get their refills done. Home deliveries increased significantly because people didn't want to come to the pharmacies and they knew they'd be home, so there weren't confidentiality issues about getting their medication delivered. We've had a huge expansion of self-testing. Dr. McCray will probably talk about that a little bit more. And for us in the Ryan White program, we knew that eligibility and recertification was a huge barrier for many people. And programs have really been able to streamline those processes to make them happen more easily and not needing someone to be in person with an actual sort of hard signature and paperwork shown in paper, which was not done in most of the world anyway today. So if we can just, they can send a picture of their eligibility or whatever it is, they've been able to do that. An important part of our process for us has really been getting listening session, really hearing from the community. So I was able to travel with CDC colleagues last year, prior to, obviously to COVID, to many jurisdictions to talk firsthand with community providers, with people with HIV, with health departments, to hear about the gap between where they are and where they need to be to end the epidemic, as well as really innovative and exciting things that people are doing differently. So what's not on this slide is we also had a listening session last year, December, at the clinical conference that gave us some great insights and really changed the way we did our work. Overall, in the listening sessions, we had some key themes that all of you know about from the work that you're doing around the importance of addressing mental health, substance use, incarceration, issues of transportation and homelessness. That in planning, we needed to make sure we included community-based organizations and people with HIV, as well as new partners in the planning. If we did the same old thing again, we weren't going to get where we needed to go. And that we needed to make sure we were training staff in cultural responsiveness, that was just a key thing that was missing in a lot of programs, including Ryan White programs for some of the populations they weren't reaching. It's because those populations didn't feel heard or welcomed in those environments. We need to address stigma. We need to do things like health education in the high schools, as well as changing criminalization laws about HIV that really drive stigma. I mentioned the workforce already. Workforce shortages are critical here. As we approach in communities want to make sure that we were leveraging strength in the communities and that we were helping and encouraging health centers and health departments to sort of grow their own, to bring in people from the community into the jobs that they qualified for, and then to train them up to assume more and more responsibility within those organizations so that people from the community would be leading in those organizations over time. Eligibility intake is, as I said, as we know, it's a challenge, and we've seen people really overcome some of that through COVID. And we want to encourage people to be innovative. And we certainly, I think, have in the way we've approached our guidance to recipients. So that is my high-level overview, and I'm going to turn it over now to Dr. McCray, who is coming to us from Georgia.
Cheever for the introduction and inviting me to participate in this important session on End the HIV Epidemic, or the EHE initiative. During my talk today, I will describe CDC's role in EHE and highlight some key milestones in the initiative. For each pillar, I'll give you an overview of some of the key strategies CDC is supporting jurisdictions to implement to achieve the goals of the initiative. Diagnosing persons with HIV as early as possible after infection is critical to ending HIV in America. Yet less than 40% of people in America have ever been tested for HIV. In fact, CDC estimates that 1 in 7 people with HIV don't know they have it. Unfortunately, the current estimates, estimated time frame from infection to diagnosis in the US is 3 years. And 1 in 4 people with HIV has had the virus for 7 years before diagnosis. CDC will increase HIV testing through a number of strategies. We will support jurisdictions to use innovative approaches to increase testing in clinical setting. In non-clinical settings, CDC will support making HIV testing more accessible through use of point-of-care testing and self-testing approaches. CDC will work with health departments, the clinical community, and community organizations to bring HIV testing to everyone who needs it and diagnose infections as early as possible. That also includes regular rescreening of people at increased risk. And CDC will work with the Food and Drug Administration and others to reduce the barriers for manufacturers entering the HIV testing market. We know that HIV treatment keeps people healthy and prevents new infection. CDC and HRSA will work with partners, providers, and other federal agencies to support effective HIV treatment for all people with HIV. CDC will fund innovative practices and scale up efforts to ensure immediate linkage for people who are diagnosed with HIV to medical. We want to immediately link them to medical care and essential support services. We want to expand innovative activities to retain people in medical care and encourage adherence to effective treatment. We also want to strengthen efforts to re-engage people who have fallen out of care and help them get back on effective treatment. The PREVENT pillar focuses on 2 key interventions: pre-exposure prophylaxis, or PrEP, for persons at high risk for acquiring HIV, and syringe services programs, or SSPs, for persons who inject drugs. CDC and federal partners will implement several strategies to increase access to and use of PrEP. CDC and HRSA will train healthcare providers on prescribing and managing PrEP, and HRSA will be funded to increase the availability of PrEP services in community health centers. CDC education campaigns for both the public and healthcare providers will combat stigma associated with PrEP use, as well as stigma associated with HIV. The HHS Ready, Set, PrEP program will also provide PrEP, donated by the manufacturer, to up to 200,000 uninsured people each year. Through EHE, CDC will work with the Substance Abuse and Mental Health Services Administration, or SAMHSA, health departments, community-based organizations, and other partners to increase access to and use of SSP. We are committed to working with health jurisdictions and local communities to implement SSP where they are needed and permitted by state and local laws. The Respond pillar is focused on identifying and responding to potential HIV outbreak as early as possible. CDC has been working to increase state and local capacity to respond to HIV outbreaks nationwide. However, we realize that not all areas have the resources to identify, investigate, and respond to outbreaks early. Through EHE, CDC will assess and address gaps in staffing, expertise, and data management systems that prevent states and local areas from being able to fully investigate and respond to increases in HIV transmissions and outbreaks in their community, and to take HIV prevention and treatment resources to where they are needed the most. CDC will work with each community to enhance the local workforce with experts as needed. Examples of areas where expertise is needed includes things like epidemiology, healthcare and information systems, client-patient services, and disease investigations. CDC is planning to increase workforce capacity through current mechanisms and creative solutions. For example, we are leveraging our Public Health Associate Program, or PHAP, to place highly motivated early career public health professionals in interested jurisdictions. 10 PHAP graduates were hired in 2019 and assigned to the EHE jurisdictions shown on the slide. 9 more graduates will be hired, or have been hired, and will be assigned to additional EHE jurisdictions in October of this coming year. I would like to spend the rest of my time providing a quick update on some key EHE activities that CDC is supporting. Since the announcement of EHE in February 2019, CDC and the rest of HHS has been busy planning and getting the initiative started. Since last summer, 3 Jumpstart sites were funded. In the fall of 2019, CDC funded jurisdictions to work with communities to develop draft jurisdictional plans. And we recently funded EHE jurisdictions to begin implementation. I'll provide a little bit more detail on each of these phases in the next few slides. So in July 2019, CDC awarded $4.5 million from HHS Minority HIV/AIDS Fund to jumpstart key HIV prevention and treatment activities in Baltimore City, Maryland, DeKalb County, Georgia, and East Baton Rouge, Louisiana. The activities implemented by each Jumpstart site are shown on the slide. For example, each jurisdiction implemented 1 or more innovative testing activities, and 2 jurisdictions implemented innovative PrEP programs. The successes and lessons learned from these communities will be shared with other EHE jurisdictions to support their implementation efforts. In September 2019, CDC awarded $12 million from the HHS Minority HIV/AIDS Fund to the 32 eligible state and local health departments representing all of the 57 EHE jurisdictions to engage the community in developing EHE plan. All 32 draft plans were submitted in December of 2019. The recipient draft EHE plan addressed a variety of issues needed to end the epidemic within their jurisdiction and among their priority populations. Some of these issues included things like stigma, addressing policies that prohibits their ability to do their work, self-testing, and social determinants of health, particularly housing and homelessness and transportation and mental health. Notably, half of the jurisdictions engaged local community partners, providers, and other partners through a wide variety of engagement activities. These included things like focus groups, community advisory boards, town hall meetings, ad hoc committees, road shows, HIV planning bodies, and use of social media, webinars, and conference calls. Actionable feedback was provided to the jurisdictions in March 31, 2019, and the jurisdictions are now working on revising their plans, and updated plans are due to CDC at the end of the calendar year. Earlier this month, CDC awarded $109 million in funding for EHE jurisdictions to implement innovative HIV prevention strategies. Of this funding, health department recipients are required to allocate at least 25% of their awards to community-based organizations who are uniquely positioned to extend the reach of prevention efforts through deep experience working with the communities that they are in and supporting those who are from disproportionately affected populations. Of the total funding amount, $3 million will be awarded to 7 communities to scale up quality HIV prevention services in STD clinic, including testing, PrEP, linkage to care, et cetera. In closing, COVID-19 is an immediate priority for CDC at this time. However, EHE continues to be a top priority. Although aspects of EHE may be delayed due to COVID-19 response efforts, the work continues. We are working with organizations and other stakeholders impacted by COVID-19 to determine the next steps in implementing EHE. This includes working with health departments and other grantees, including community-based organizations, to assess what critical work can continue and what is being put on hold at this time. We are also exploring creative and innovative ways to advance HIV prevention, including our important EHE work in the context of the pandemic. For example, the availability of HIV self-tests may help increase awareness of HIV infection for persons who cannot otherwise get to a clinic or other place to do an HIV test. Self-testing allow people to take an HIV test and find out their result in their own home or other private location. So this includes my presentation on CDC EHE activity. So I want to end here and thank you for your attention.
Thank you so much, Dr. McCray. And one of the really exciting things for me in this working in this initiative has been the incredibly close working relationship we've been able to foster and sort of enhance with CDC. So next, we're going to turn to Dr. Victoria Cargill in Baltimore. I'd like to encourage everyone that has any questions to start putting questions in your chat for the question and answer period. Dr. Cargill?
I'd like to thank the conference organizers and the senior leadership at HRSA for inviting me to share with you a way that we in Baltimore are trying to work to reduce our cases by getting to zero. Plus, the view from Baltimore, or what I like to read it as, is the tale of two cities. I like to begin my presentations with a story that will help highlight the situation. This picture of this gentleman may not be familiar to some, but this is Glenn Bias. And Mr. Bias in the 1980s and 1986 was the second round draft pick for the Boston Celtics, felt to be an outstanding basketball player from the University of Maryland, and envisioned by then coach Red Auerbach to be able to take over for Larry Bird, and some had even surmised could have become better than Michael Jordan. However, Mr. Bias died before he could do that from a cocaine-induced heart attack. This was Baltimore in the 80s. Now, as you can see on this side, HIV in Baltimore very quickly took off, with cases beginning below 100 and quickly escalating to almost to 14,000 by 2010. This is important background against which to look at what we propose for ending the epidemic. However, change came to Baltimore, and this is a slide from the Journal of AIDS program on the AIDS linked to the intravenous experience data, which demonstrated the impact of syringe support programs, decreasing the prevalence of HIV among injection drug users from at the beginning around 66% to now, and at that time down to around 8% and subsequently down to 6.9 to where we are now between 6.9 and 6.2%. In addition, we have seen decreasing new HIV cases from 318 in 2015 down to 278 in 2016, 227 in 2017, and 224. So clearly it was time to build upon this increasing momentum. Not only were we seeing decreasing cases, but transmission patterns were changing. Those living with HIV were not engaged in care were now significant contributors to the epidemic, and we knew that engagement would not be easy. It would require listening, engaging, creating, and persisting. But this was a terrific opportunity, an opportunity to build new collaborations, to expand existing ones, and to engage across sectors, communities, and agencies. We tried very hard to make sure we incorporated the critical feedback from consumers and stakeholders in our activities. And thus, Getting to Zero Plus was born, building upon the Johns Hopkins University Bartlett Clinic experience with the REACH program created by Dr. Jason Farley. Between July 2019 and May 2020, Getting to Zero program was instituted at the Bartlett Specialty Clinic, and 136 eligible patients with a detectable viral load were identified, 126 of whom were reached by the Getting to Zero Navigator. Of those 126, 90% were male, 90% were Black, 81% were age 35 and older, and almost a third reported same gender sex, and almost a quarter injection drug use as their mode of HIV exposure. For those patients with more than one repeat viral load, 70% or 79 achieved viral suppression with the program, and 20% achieved a sustained viral suppression defined as less than 200 copies for more than. For you to focus on is that overall, about a third of patients received 10 or more community health worker encounters, and these were not high-tech interventions. These were telephone contacts, primarily scheduling appointments, giving reminders, providing transportation and emotional support, and helping with systems navigation as well as advocacy in the clinic and the community setting. There are several pillars that are critical to the Getting plan: education, capacity building, and information dissemination for both providers as well as for clients; technical assistance to the clinic so that it's not just HIV testing and linkage to care, but utilizing navigator support services with an information, motivation, and behavior adherence model, as well as managing the data and providing support to manage the data from which one can identify those clients that have a detectable viral load. In addition, this data is utilized to inform the Getting to Zero provider support, and finally, critically, evaluating the effect of the intervention. I love this quote from Dr. Farley. He calls this being unapologetically enabling, and that is really what Getting to Zero Plus does. It is essential to remove any of the potential barriers to linkage and access, engagement, retention, and adherence, but it's also important to focus on community solutions. So this program goes far beyond the brick and mortar to create opportunity outside of our traditional spaces, facilitating communication outside of traditional clinical hours, and also supporting a new type of client-navigator relationship. What you see on the right-hand side of the slide is a screenshot from the app that's been created for the community health workers to use that helps them focus on the different pillars in which to check in with our clients, and that's mind, body, spirit, as well as health and wellness, and of course, sexual health, with the mantra being, how can I help you? The overall goal is viral suppression, and this is achieved in several ways. Community health workers in clinical settings and the hybrid community health worker disease intervention specialist in our mobile settings, and I will come back to that. Navigators link and engage individuals into HIV care with several goals, of course, including maintaining this care linkage, improving health outcomes, maintaining viral suppression, reducing HIV transmission, and of course, providing for a fast response for those newly diagnosed cases. However, Getting to Zero Plus also targets the reservoir of undiagnosed, unengaged, and virally unsuppressed individuals in our communities with a specific focus on youth, young men who have sex with men, racial and ethnic minority women, formerly incarcerated, and the marginally housed. And our partners in this effort reflect this target. And finally, the Getting to Zero Plus Navigator linkage and engagement program is customized to meet the unique needs of each of these targeted populations. So for example, I mentioned our mobile settings. The community health worker disease intervention specialist hybrid is a direct response to the concerns we heard raised by many in the community who felt that it was traumatizing to have to repeatedly tell their story as to how they acquired HIV. And so in this way, anyone who tested positive and interfaced with this DIS community health worker hybrid would be able to complete the mandatory partner services interview, but then the individual could then proceed right into support without having to have the individual tell the story again. It also means that that individual can be there for an individual to return to the mobile setting to do anything that would be helpful from the client's perspective, from providing a gift card for food support, to actually going with the individual to the appointment. This is a basic overview of how the program setup works for a brick and mortar setting, which is the Federally Qualified Health Center example. So the first thing is the site would need to determine who their Getting to Zero champion is. That would be the individual who serves as the coordinator and helps really promote the program. It would be important for defining and collaborating what's going to be the data sharing and confidentiality agreements, because for community health workers to provide targeted support, they will need to know specifics about the case. Similarly, careware data analysts and updates in terms of viral load reports, similarly as what was done with the pilot project. It's helpful for determining the staffing needs. There is definitely a need for an on-site case manager who will work closely with the Getting to Zero program. Monitoring and evaluating are another key component of the setup, not only identifying reporting structure, but also setting up the provider dashboard to be able to track reports, look at aggregate data for the quality of the program, and to tweak the program. And finally, using careware and standardized tools and metrics that have already been designed by the REACH program to help the clinic follow its response to these interventions. So the Getting to Zero Plus Navigator interventions include, for example, in their initial outreach, which is often by telephone, assessing barriers, scheduling a time to meet at the location of the patient's choice. Many of these meetings occur in the community at bus stops, in coffee shops, anywhere but the clinic very commonly. As we move into in-person and in community work, the Getting to Zero Plus Navigator critically assesses the patient's environment and barriers to adherence. It also takes a look at immediate health and psychosocial needs, from housing, showering, insurance, benefits, getting identification that's needed, other referrals such as emotional support, and coordinating with community partners for services. And this is where, with our intervention, we're fortunate to have very diverse, unique, but very creative and gifted partners. So for example, we have Star Track, which has a very long track record with youth and sex and gender minority, non-binary, who are living with or at risk for HIV. In addition to that, we have New Vision House of Hope, a unique housing organization, which doesn't just provide housing, but is also state certified in behavioral health as well as substance use, and houses individuals for periods of time up to and exceeding a year. And that is because the philosophy at New Vision is that without addressing the underlying behavioral and substance use issues, the individual is destined to repeat the revolving door of homelessness, which they strive to avoid. So in summary, Getting to Zero Plus really builds upon an existing model and expands it to be responsive to not only consumer feedback, but also to allow us to be as nimble as possible in our mobile and street settings. While the overall goal is viral suppression, care engagement, enhancing trust, and removing barriers to care, and I should add here, care linkage, are equally important. The team is a collaboration of new as well as existing partners, including novel housing services and established syringe support programs, and creativity to meet the needs of the population, such as the community health worker DIS hybrid, was needed to accomplish not only the mandated activities, but also meet client need. Community health worker input is really essential for identifying barriers to care engagement, and especially those that are either overlooked or may seem unimportant. An example of that is a phone tree. We learned from the Johns Hopkins experience that for many clients, the phone tree, which many of us dislike, dial 1 for this, dial 2 for that, dial 3 if you've had enough, found that overwhelming and invariably would end up hanging up. And so the community health worker not only could navigate the phone tree, but very often developed a relationship with the clinic and could expedite appointment making. So in the city where we certainly have so many challenges, this provides a structure upon which to build collaborations and interventions. And I would be remiss if I didn't acknowledge our many partners in this. First of all, Dr. Jason Farley, Kelly Lowenson, Nikita Wilson, and his entire team at REACH, Our Ryan White team leads that you see listed here, Dr. Ferrari, who leads this ABLE team, our Part A staff who really rolled up their sleeves and embraced this model and did their due diligence to take a look at how to incorporate our existing programs as well as expand it. New Vision House of Hope, Dr. Towson and Mr. Culver, who have been instrumental in making this available to us so that when housing issues surface, we have an option for them. Our syringe support services and Star Trek, Dr. Vicki Tepper and Dr. Matthew Grant. And most importantly, a huge thanks to all the patients and the consumers who attended focus groups, who attended our Ending the HIV Epidemic community sessions, and provide us with a vital feedback which allowed us to shape this program. Thank you.
Thank you, Dr. Cargill. That was great. I think we're all looking forward to the results of that citywide endeavor. It's now my pleasure to be speaking with Dr. Houlberg from Howard Brown. Welcome. Thank you for being with us today.
Thanks. Thanks for having me.
Great. So I really wanted to have you come here today because we know you have some very practical experience in using telehealth, and we wanted to hear about it. So can you start by just giving me a short description of the health center and the background of your program, when you started, what kind of services you've provided in the past?
Sure. So Howard Brown Health is a federally qualified community health center. So we were founded as a community-based organization in 1974. And to serve the LGBTQ community. So we've grown quite a bit and have an expertise in LGBTQ care. We provide a lot of HIV care, PrEP, sexual health, and gender affirming care. So we have 11 locations throughout Chicago and about 38,000 patients, 5,500 of which are living with HIV.
So in terms of telehealth, were you providing telehealth prior to COVID-19?
No, we went to a completely telehealth clinic within about 12 days. So we, subsequent to the stay-at-home order, we basically kind of launched us into telehealth across many of our service lines. So that includes our behavioral health, medical, PrEP, sexual health, and even dental. There's some dental visits that we've been doing telemedicine wise.
Wow. So what's been your experience with telehealth? Are there areas that you think have been particularly useful?
Yeah, I think it's been really wonderful in a couple of different ways. So for many of our patients, they traveled quite a bit to get to us, even though we have 11 locations. And this really removed a lot of those barriers. So we have patients who are in downstate Illinois, for example, who would have to travel like 6 hours both ways for visits. And that removed a lot of that restriction. So I think with having the ability to do telehealth as an option was really liberating for a lot of our patients. There's a few different ways that we think it really benefits people. The transportation and distance is one. Also for patients, I think, who experience trauma or in some ways being at home or is actually more comforting than being in the clinic. And it's surprising because there were things I think that we assumed about patients that would not be good for telehealth that actually turned out to really appreciate it or really enjoy it as an option. And that was, kind of surprising for us.
Yeah. So do you think there are some patients, can you describe a few of those things? Like what are the sorts of things that really worked for certain types of patients that you just didn't expect?
Sure. I think we thought that patients with a lot of chronic disease, so patients with complex chronic disease might be difficult to assess in a telemedicine visit. And we found that if we knew the patient very well and they were well established, so for example, if they were a patient that was in HIV care already, we were really able to manage almost everything in a telemedicine visit with the exception of labs. So labs and procedures obviously are much more challenging, and we've come up with a couple of workarounds that we think has been really great for patients. But of course, it's changed how we do medicine. So Many of the medical providers really have to approach it differently. We provide some support with like kind of a weekly drop-in where providers can talk about patient cases, for example, because it's very different to manage in this way. And so for newer clinicians as well, it can be a little nerve-wracking. So yeah, so chronic illness this has been great for that. Patients who are struggling with trauma or PTSD, this has been wonderful for. And then sexual health, which I think that we knew that PrEP visits were pretty quick in person, particularly when the patient knows a lot about PrEP. We're just keeping them on PrEP, keeping them healthy, and doing sexual health screening. Those patients do really well in telehealth, partly because there are usually not other complicating factors.
So are you doing then self-testing? Is that part of your PrEP work? Because I know that's come up as a question in the meeting here.
Yeah, we have been. So we did it in two different ways. So we organized it so that we would have the telemedicine visit with the patient, and then we would offer it as an option. So we'd say, we can mail you some self-collection for labs, and then you mail it back, and then we'll send it to the lab. So that has worked pretty well. It requires staff to be able to package that up. And then there are vendors that are able to do this. So there's vendors that we're looking at and working with now that are able to mail a box of self-collection labs. So it does require, it's pretty smooth with sexual health screening and HIV screening. I think where people struggle with PrEP and having a kind of complete virtual clinic is with creatinine. So if you're really worried about that, we generally are not as worried because we just are not seeing a lot of creatinine issues in patients that are pre-screened. So it's really not a huge issue or worry for us, if particularly if we're seeing, and additionally, we can also have patients go to a patient collection lab. So that's the other way we did it, is we worked with our lab vendor and are able to send lab orders and kind of try to manage that with the patient. So we have to tell them, well, I found this place, it's close to you, it's a patient service center, I've sent the labs over and faxed them, and here's a copy of your lab orders. Right. Go on in and make an appointment for labs.
So in those places, will they do, is the patient self-collecting like their pharyngeal swab or their rectal swab, or like, how does that work in those kind of places? Sure.
Yeah, they don't. Meaning that with swabs, it's something that we practice self-collection in our clinic because it's more well received. Although we'll offer provider collection. In that kind of setting, they won't do that. So in some ways, it's a combination. So we really rely upon the lab vendor in person for phlebotomized labs.
Okay.
But yeah, I don't think that they'll accept self-collection because it's unconventional in some cases for the lab vendor.
Right, and I understand. Okay, and so what are some of the trade-offs you've seen with moving to telemedicine?
Yeah, I think a lot to do with the digital divide, which I think a lot of folks are experiencing that, which is that their connectivity may not be great, their telephone access, telephones get shut off. Particularly, in economic difficulty times, it's one of the things to go off of someone's budget. So I think those are areas. Some of the older adults that we serve, I think, are struggle a little bit with the technology. But I think with a fallback of phone, it's been pretty good. So phone seems to be manageable for most people. But yeah, there are definitely situations where we are not able to manage the patient, or would be, and I think someone who's newly diagnosed with HIV, for example, would be, I would say that that's something that we have to manage in person.
Yeah, because I think one of the things I've heard from my patients is patients that are often socially isolated, going to the doctor is sort of an outing. And several of my patients sort of, even though they came from far away, wanted their next appointment, the first possible appointment I could get in person, to be in person, because they wanted to get out of the house and come and see us and see everyone in the clinic. I don't know if that's something you've experienced as well.
Oh, absolutely. So for a lot of our gender affirming care, so we do a lot of HRT and so forth. For some of our patients, we're the only space that might be trans affirming that they go into. So I have patients that where we're the only place where they feel at home. And so it is really important actually for them to come in person, even with the added risk. So I think that, and we see that with HIV and stigma as well, meaning that people living with HIV may often feel isolated or stigmatized. And in reality, our clinic is warm to that, meaning that we're going to warmly receive people, and that feels good.
Mm-hmm. Yeah. So what are your plans for telemedicine moving further in the future? Are you back like seeing patients partly telemedicine, partly in person? And like, what do you envision in the next 2 or 3 years?
Sure. We have a combination right now. So we're doing in-person and telemedicine. So by combination, I mean that we are having full in-person visits and full telemedicine visits. And providers shift off of telemedicine into in-person. So they go, and that's how we've managed it so that people are able to stay with their provider and also have the option to access that way. So we expect that a significant number of our patients will remain telehealth based. And I think that we're still working on how we're going to get into a rhythm with them in terms of coming in person. And how much, for how long can you do telemedicine with a patient in that scenario?
So have you guys thought about how you're going to manage sort of patient preferences where somebody might prefer telemedicine most of the time, but you really want to do a rectal and pharyngeal swab on them every 3 months? Like, how are you managing that?
Yeah, we really are. We go at this from a patient-centered perspective. So we'll have a conversation with the patient about the things that can be missed if you don't get a rectal exam, and are they comfortable with that? So the idea is that we want to meet the patient where they're at. So patient preference drives it. That often is like a little bit tricky with COVID, obviously, because you're kind of like, you know what, you really should limit your contact with other people, and coming into clinic might not be the best idea. But I found people to be pretty reasonable. Patients have been pretty reasonable and self-protective in their choices. But yeah, we don't really want to tell people that they can't come in person. So I think that we want the door to always be open.
Great, thanks. Anything else we want to cover that you want to say that you didn't get to cover?
No, I don't think so.
Great. Well, thanks so much for sharing your experience. I said we had lots of questions around it, so people really wanted to hear about how people were doing that. Thanks. So I'm going to turn it back over to Michelle, I think.
Yes, thank you so much, Dr. Cheever and panelists. So we have a few questions from the audience. One is, what do you see as the role of federally qualified healthcare centers in these EHE initiatives? Is there a plan to increase Ryan White programs?
Yeah, so I'll take that to start with. We've actually got a health center on the line with us, which is great. We are letting communities decide how they want to do their expansion. Clearly, we need to expand we have to have new providers if we're going to really have 400,000 new people in care. And I think health centers are the place to do that. But I think across the board, they're really going to have to up their game around cultural competence. We have places like Howard Brown that were sort of based in the LGBTQ movements in their communities. But a lot of health centers weren't that welcoming, frankly, which is partly why the Ryan White program was started to begin with, is because not just health centers, but clinicians in general weren't welcoming of people with HIV. So we're going to have to really work on that, I think, in order to grow the health centers. I don't know if you want to say anything, Dr. Houlberg, about your view from Chicago.
Sure. I do think that federally qualified community health centers are really well situated to serve people and do prevention, particularly PrEP, but also HIV care. I think it's more that we have to make that a priority within the FQHC world, and also to provide kind of the necessary support that people need to learn HIV care. So I was able to learn as a primary care provider. I'm an internist and geriatrician, and I learned HIV by working at Howard Brown. So that was something I learned in the field, working next to many clinicians who were able to work with me with patients. So that's a tougher thing to develop in an FQHC, depending on where it's located.
I think it's something that's absolutely essential. Certainly in our Getting to Zero Plus program here in Baltimore, we've built into that the community health workers as well as the providers interact together as they go through the program and as we identify their clients. So for example, for the providers, we use the National HIV curriculum and then switch to a monthly format where they can present cases and teach each other. And the same for the community health workers, so that I think it has to be done on multiple levels and done in a way that people feel comfortable. Our partners are particularly diverse, and that was intentional. So for example, our partner that has an over 20-year track record with youth who are non-binary or LGBTQI, they are also going to be part of our teaching staff to help identify and help federally qualified health centers understand what does it mean to have a welcoming environment and how does that get done from the community health worker perspective all the way up to the provider.
Yeah, and community health workers, half of their board needs to be members of the community, and they take care of they really have a lot of expertise in quality improvement. And I do agree with Dr. Houlberg. And at this point, I can say that the Bureau of Primary Health Care that administers them, they're all in on this. So I think that they will increasingly see HIV as a priority from at least their federal guidance.
Terrific, thank you. Clinics want to know how to find out about the available EHE, HRSA, CDC funding moving forward.
So that's a great question. We funded the Part A's, which are the city funded grants in 39 cities that contain those specific counties. So that funding is available there, and they'll be issuing subcontracts. A lot of them haven't really started that work yet because it got caught up in COVID. Similarly, we funded the 7 states with predominant rural issues in terms of HIV diagnoses. We funded the state Ryan White provider, so you should reach out to them and talk about your interest and ideas, because this planning and this sort of subcontracting is still ongoing, and we've asked for a significant increase in the president's budget. So we had a relatively modest amount of money that went out in 2020, but that amount will increase significantly if Congress follows the president's request in the budget in 2021. So this program should be expanding and adding new partners every year. Eugene, do you want to comment on that from the CDC perspective?
Yes, I am. I was trying to unmute. So yes, so CDC also has recently, just as of August 1, funded the 34 jurisdictions that account for the 57 EHE sites, and that includes the 7 rural states and then the state health departments that are responsible for multiple counties. And they just got the money, so that money is going to be going to the counties. Most of that money will be going to the counties, and the state and the counties, in collaboration with the communities, are deciding how that money is allocated. But I since they just got the money, I think it'll be a month or two before you start seeing any money in getting to the ground. Now, one of the things we did stipulate in our cooperative agreement was that at least 25% of the resources that go to the county must go to community-based organizations, because we think that they need to be a really, at minimum, we encourage jurisdictions to do even more, but at minimum, 25% of those resources that are going to the counties must go to community-based organizations. And as Dr. Cheever said, we have, similarly, CDC has requested significantly additional resources in 2021, and we will see what happens.
Great. We have perhaps one more question. There are a few questions on there about, with the focus on FQHCs, what about the pure Ryan White centers, especially in rural areas where FQHCs have been historically reluctant to see patients with HIV? And what about the academic centers and standalones that often are the safety nets for folks who are otherwise not wanted by other settings?
Yes, so we definitely see that a lot of those settings are going to continue to have increased patients and should get increased funding from the jurisdictions related to the EHE funding that's increasing. The challenge we've had is around PrEP and really expanding PrEP in those locations, because obviously it makes a lot of sense that they would be well equipped to do that. We're just prohibited with our current Ryan-White statute, which is up beyond its time for reauthorization. We're prohibited from doing PrEP in Ryan-White programs. So that part will not be funded through us or through the health centers. I think CDC has some plans in terms of when they're funding the cities that the states or the cities might be able to fund PrEP in a variety of different ways or support PrEP.
Yeah, so I can just add to it. So yeah, we are targeting both, we are targeting in collaboration with BIPIC community health centers, but also private providers, clinicians or private clinics that are non, when I say private providers, non-FQHCs that are in communities that are able to and willing to provide PrEP. And so we're working with the state and local jurisdictions and the community to identify those sites. Now, one of the things that we do know from the community plans is that, you know, some of the communities didn't have the opportunity to do as much planning as they needed to. So they're continuing to plan now. And many of them, based on feedback that we provided them on their initial plans, are beginning to reach out to more community health centers and other community members to really better identify folks in the communities that can help with PrEP expansion, as well as with a lot of the work that will be required to link people to care once they get diagnosed, et cetera. So there's a lot, there's still more planning that needs to be done, and that planning is being done collaboratively with HRSA and other HHS entities.
It looks like we have a minute and a half left, and I think we could scooch in and answer a Q&A there for logistics. So with the telehealth and the telemedicine options, which are really terrific, that a potential benefit of the COVID, more providers are utilizing that. But what about our patients? Are we actually creating more problems with disparities for those who don't have the technology or the access to the internet, et cetera? How are we going to address those particular populations?
Yeah, I think that's a great question. So we've really looked at in COVID, in this sort of post-COVID or current COVID world, we're really looking a lot at mobile health. So going to people's houses, even if they're not, or wherever we can meet up with them. And that's been a strategy that we're employing to reach some of the patients that we know are not going to be able to do telehealth. So yeah, I think it will drive disparities, you know, because I think social determinants of health are the biggest driver of all of this. So until we can address that, it's going to be very difficult to have telemedicine be a leveling field for equity.
Yes. No, I completely agree. And there are other examples, and there are some examples of communities, of counties and community-based organizations that are leveraging COVID resources to actually go into communities to do mobile health. So that's something that that is happening in a number of smaller communities.
Yeah, the final word on that is in the Ryan-White program, we have encouraged people to look at, you know, buying phone minutes for their patients. I think some people have been buying iPads or other platforms for their patients, and those are allowable costs under the COVID funding. Yes. From Ryan-White. So that's just another way of trying to get in there and help a little bit.
Thank you.
Great, thanks. And thank you, Dr. Ian Diorio for moderating that. We're now going to move to the closing of the meeting. I can't believe someone told me we'd blink and it would be over, and apparently that's true. So thank you all for that presentation. That was really fabulous. I appreciate that. So just in closing out of the conference, I want to say a few things. The first is I want to thank my co-chairs. Dr. Sag is our perennial, and he is fabulous. And Dr. Ian Diorio, really thank you so much. She's been a huge leader in Echo HIV. She was one of the first and has really propelled us forward in that field. So thank you both for all the work that you did to make this conference possible. Please do not forget to complete your evaluation. If you go on today, you need to complete today's evaluation, the final evaluation, which is how you can get your CME. To get your CME, you need to sign into your IAS-USA account. It will be there. So just follow the instructions. It's that gray starburst icon, number 3, that always throws me off, but I've learned it by now. So follow the instructions. They're very clear, and you can get your CME. We have been thrilled at the number of people that have really participated throughout this event. We didn't know if people would sort of turn on the computer and then start to do their dishes or whatever, but that does not seem to be the case. We've had people looking at the schedule, doing the live polling, looking at the materials, and doing your evaluations. So thank you so much for your incredible engagement throughout. We have not had as many people participating in the networking chats and forum, and I think that's just part of us being socially distanced. We do have the top 5 engaged attendees. We have all sorts of metrics because we're online. So a big shout out to the 5 of you who have gotten points assigned for all the different things you've been doing in the system. So thank you so much for leading the way in engaging in all the different materials that we had put forward. A reminder from earlier today, the platform will be available for a year after the conference, so you're encouraged to use the different features, including some of those features of hooking up with various colleagues through some of the social engagement features. Both at the IAS-USA website and on the platform, we're going to have a series of resources, including the webcast of the lectures, a webcast of the breakouts, PDFs of the slides that we were using, and a slide guide for you to use with your colleagues. When we first started this program, it was really about making sure you went back into your individual clinics and updated your colleagues, so please do that. As we noted earlier today, we are going to be able to have all the breakouts for CME credit. So all the breakouts that you missed, you can now go back and watch. I know for me it was really tough. So you have the chance now to get new CME under a different, there'll be a different sort of activity code, but you'll be able to get your CME for the other ones that you watch. And a huge thank you to the leaders of the breakout sessions. I think all the faculty was a little stressed. You may not have known that about the different platforms and how to use them. We've all been using Zoom, but this just felt a little bit different. So I want to thank all of the speakers, both for the plenaries and for the breakouts. And a huge thank you to the IAS-USA team, Donna Jacobson in the lead, but also Stephanie, Michelle, Fatima, and Tammy in particular, who just were doing all sorts of things, getting the speakers in line, getting the content in line, doing the registration, continuing to do the registration, adding more people to the registration. It could not have been done without their tremendous efforts and flexibility and really learning on their feet. We keep saying, oh, we're doing this all the time. We're not really doing this all the time. So this is just different than Zoom, and it was a lot to learn. I learned so much last Friday. It was a little bit frightening to me. I did not sleep on Friday night or Saturday because it didn't seem like it was going to work, but it did. So thanks to everyone for that. And that really is a huge shout out to PSAV. The team here, we're in this big hotel ballroom where we can be socially distanced. Tremendous work. We didn't lose a speaker over the time, which I think is pretty remarkable. So thanks to all of you. I did not know what I was doing, and they made it look like I did. So that was big. And also the National Coordinating and Resource Center, NCRC at the AETCs. Thank you to the staff there, particularly John Nelson and Andrea Norberg, who make this happen, really guide us through this entire process. And finally, before I leave, just another big thank you to me for all the work that you all are doing in your communities every day. I can't tell you the number of people that have gone above and beyond to make sure their patients had medication in hand when they were supposed to in the early parts of the pandemic, that people felt they were getting the care they needed, and that you can see even now as we start going back into potentially being in the clinic seeing patients, all that you're doing to make it work for your patients. So thank you so much. I really appreciate it. And we look forward to seeing you at the 2021 National Clinical Conference I have a feeling it might be virtual, but potentially it'll be in person. So thank you all. Thank you so much.
Dr. Cheever, before we
You
leave,
want to say you're on mute, Mike?
Okay. You can't hear me?
Now I can.
Okay, great. Well, I just wanted to also say thank you to you, because all the work not only that you do for all of us every day of the week, as well as your team in supporting what we do in the Ryan White clinics where I am in right now, but also for what you did to make this conference happen, not only this year, but every year for the last 20 years. So we're very grateful to you. So a big round of applause for you as well.
Great. Thanks so much. Thanks. My pleasure. Thank you. Thanks, everyone. See you next year.